Pamda, Mountain Pacific. And today's webinar will be about 30 or so minutes in length, maybe a little longer depending on the amount of questions we have. After a short presentation, we will open the floor to questions. Actually, after a short presentation, we're going to have a little poll for everybody to talk about our needs. So anyway, at this time, if you can enter the names of all your attendees in the chat box for attendance purposes, that would be great. Unfortunately, we are not offering CMEs due to time constraints, but we can offer certificates of attendance after you do an evaluation. And the evaluations can be found on our website under the evaluations tab by following the link in the chat box. And if you haven't already registered, we encourage you to do so after the webinar. Okay, so today's topic is getting ready for telemedicine. And today we have some special speakers. We have Amy Grace and Dr. Christine Higa from the UH Pacific Basin Telehealth Resource Center. We have Sylvia Mann from UH, and I think Jennifer Mabuthia is there as well. And I think we're going to have Mark Marabella from Mountain Pacific joining as well. So with that, I'm going to open the floor to, I think Sylvia, right? You have slides?
Thanks, Christina.
Oh, okay.
I'll jump in. Are you seeing the slides?
Yes.
Okay, great. Hi, everyone. I'm Christina Higa, and I'm the co-director of the Pacific Basin Telehealth Resource Center at the University of Hawaii. And joining me today will be Sylvia Mann from the Department of Health, Genomics Section Supervisor. I'm so excited to see, looks like we got about more than 60 people on the line today. So we'll try to get through this topic quickly on telehealth, kind of an introduction, just a general overview of telehealth. And our purpose was really to share some information with the understanding that many of you are already transitioned to telehealth, or you're thinking about it, or you're just getting started. So we would like to plan some follow-up training sessions specific to this LTSS group. And our first session will be on Thursday next week, April 30th from 1 to 2. And specifically for facilities that are just getting started or thinking about doing telehealth. And we will give you more information on that later on in the program today. So going to the next slide, I wanted to just very briefly introduce our program, the Pacific Basin Telehealth Resource Center. We are one of 14 HRSA-funded resource centers in the country, and our coverage area is the state of Hawaii and the Pacific Islands. Next slide. Just to get started, we wanted to lay out some definitions because the way we talk about telehealth today has been changing a bit because of the way it's getting reimbursement works. I'm not going to spend a lot of time talking about reimbursement in this particular presentation, but I wanted to just share some of the little differences and nuances of the definition of telehealth as we're hearing it nowadays. So telehealth services is really, interactive audio and video that's meant to replace the in-person visit. That's kind of the traditional, when you think of telehealth services, the pure services that gets paid as in Hawaii parity, for example. Other kinds of services that are popping up include virtual communication services. It would include like quick check-ins, virtual check-ins, could be by audio, telephone, or by video conference. E-visits are communicated with online patient portals. E-consults is actually between provider to provider, not provider to patient. And more recently, Medicare and Medicaid are now paying for telephone E&M consults. So that's evaluation and assessment sessions that can be conducted over telephone. It's like 3 different codes based on time. So I wanted to put that up there because you may be hearing from the providers that support your facilities that they want to do various types of telehealth, and sometimes it's going to be beyond the traditional interactive video conference, and sometimes it
Turn
just
down
these
the
quick
volume on your
check-ins. I'll just make a quick announcement here that perhaps if you can check your mute, if you're if you're not intending for us to hear you speaking, please mute. Thank you. Okay, we'll go to the next slide. So, as you can imagine, telehealth has just expanded amazingly in the last few weeks. And last week, Thursday, the governor and lieutenant governor had a press conference specifically on telehealth. The whole purpose of the press conference was to raise the awareness of telehealth as an alternate means of getting healthcare for the general public. So the slogan, kind of the unified message was call before you click. The idea was we want to continue with the social distancing, but we want people to still and continue to receive their care. And if appropriate, to use telehealth. So what went out to the public was call your doctor first, find out if telehealth is something that is suitable for the kind of care that you need, and then schedule your telehealth appointment. In the same press conference, we had the governor, lieutenant governor, Queens, HPH, MedQuest, University, and HMSA and others that were also promoting the need for using telemedicine because it just by nature is really practicing distancing, right? Physical distancing, but also that it's really necessary to help reduce the unnecessary exposure of not just the patients and family, but the staff in your facilities and also the providers. So trying to keep everyone safe by, doing everything that we can to continue the care and practice social distancing. But also was brought up in the press conference a lot was this whole helping with the concerns of the PPE inventory. So the less people that's coming into, providers coming into contact into your facilities, and the less PPE also that would need to be used. That came up in the press conference as well. Next slide. I think that I wanted to touch on this slide of what the benefits are that had even been in place before COVID. So before all of this happened, as a research center, it's been over 10 years really that we have been trying to promote telehealth. And in particular for your type of facilities, the benefits include, very convenient, the convenience for your residents and families, the reduced burden of any unnecessary visits to the ED, hospital clinics, or even just the coordination to transport some of the more difficult patients to bring to these appointments outside of your facilities. Across the country, we've been hearing about the much needed support of your overworked and stressed staff in your facilities, and that perhaps the telehealth will help to augment, some of the clinical services that are needed. And that could be maybe even expanding some of the night and weekend visits that may be only by telephone now. Perhaps there's some opportunity to expand that. There's also, I found that some facilities said that once they started to incorporate telehealth into their workflow, it became something of attraction to when they were doing staff recruitment, because their staff knew that they would be able to very quickly get support, advice, and direct services via telehealth. And certainly for some facilities like SNFs, telehealth has been seen to reduce the hospital readmissions, so it would then potentially help improve some of the bottom line for your facilities. Next slide. But before COVID, you may have been thinking, well, where was everyone? Because we only had about 20% adoption of providers using telehealth. And what I'll talk about later is particularly for the Medicare population, there were so many restrictions. So it wasn't as easy as it is in this emergency period. So let me kind of just, I'll explain that in a bit. But I wanted to put this slide up there to show you the numbers that we are hearing just even as early as last week and early this week, today. Queens has a 40% increase in their telehealth. HMSA said 300% increase, with Kaiser saying 80% of their total visits by done by Telehealth and each page with 50%. So now it's become a way of practice. It has to, right? Next slide. Okay, so actually, this is where we're inserting our first polling question. Sylvia, are you ready for that?
It's not me, it's the UH people.
Oh, I'm sorry, John. Sorry, we switched that again. Okay, so here we go with the first polling question. Just answer number 1, please. So my facility, either A, uses telehealth regularly pre-COVID, B, just started using telehealth because of COVID, C, would like to start using telehealth, or D, would not interested in using telehealth, and submit. And stop there and submit. So did we want to take a look at the results later, or we'll bring them up now?
Let's do it later.
Okay, let's go back to there. So thank you for that. We only have one more short poll after that. Let's go to the next slide. Okay, so the next slide, Sylvia, if you could go to the next one. It's really very high level again. I did want to not spend a lot of time about reimbursement, but just to give you an idea of what changes have been happening at the federal and state level with the emergency policies that's really paving the way for telehealth to be used widely during this period. The first thing is, as I mentioned before, Medicare was very restrictive before. So a lot of the restrictions that prohibited use of telehealth has been lifted. For example, there is no limitation on where your patients are, rural, urban, in their home, or it doesn't only have to be a healthcare facility. Eligible services, there has been some expansion. There are several, but I just noted the home visits. You can have new and established patients via telehealth in your private residence. And then eligible providers included FQHCs and rural healthcare clinics. And the modality we'll speak about a lot later on in the presentation. So I'll skip that for now. Next slide. I also pulled up what I could find on LTSS. You probably know this already, but just wanted to add it in there just in case. For skilled nursing facilities and nursing homes, physicians and eligible non-physicians may provide services to residents by telehealth as appropriate. Also, you may have known that there were some limits on the frequency of when telehealth can be given for different scenarios, up to like once every 30 days. Those frequencies have been waived. For hospice physician or nurse practitioners may use telehealth for your recertifications. And CMS also permits the routine care, home care by telehealth if it's feasible and appropriate. They did note that it must be included in the care and the care plan and specify the patient's needs that it's meeting. Next slide. This is my last slide on policy before we turn it over to Sylvia. But I wanted to note that our Hawaii state law, even before this emergency, is very progressive to support telehealth. So it allows the payment to be the same, whether it's telehealth or not. Malpractice insurance is required to cover it, and it lists all the different restrictions that Medicare just lifted. In addition to that, Governor has signed at least three specific clauses in our emergency proclamations to, again, help match the federal waivers to state, so that we had similar state waivers so that it could actually pave the way. So now I wanted to introduce Sylvia Mann. I mentioned before, she's head of the Department of Health Genomics sections, but she's also the chair of the Western Region Telegenetics Working Group. Sylvia has been an advocate for telehealth for many, many years and practicing telehealth for probably more than a decade. So she's going to talk to you specifically about an overview of what's needed to get started. Sylvia?
So this is just a big overview because, as Christina said, we know that everyone has varying levels of readiness for telehealth. And so we want to really target our technical assistance to help people in the various areas. So we don't want people that are way far ahead to get bored with very simple things, and we don't want to overwhelm people who don't even know what device they want to use with very complicated things. So some of the things that we always talk about when we talk to people about starting telehealth are things like what their staffing is. Are they going to have a dedicated person? Is everybody going to do this? Are they going to be bringing devices to where their patient or resident is, or is there a designated space that is set up somewhere? What kind of equipment do you want? That can be determined by what you want to do with your telehealth. You could do everything from a full scale, full on exam with equipment that's attached to your telehealth equipment with the lovely expensive stethoscopes and the blood pressure monitors and the pulse oximeters if you want, to a very easy tablet that could cost you $100 where you're just having a conversation with your provider. So depending on what you want to do, you can have a variety of different choices for equipment. Also, whether or not you need to move it from place to place. I mean, one thing that I've always wanted to get are the robots that I could put my iPad on, that I can like make go into patients' rooms and talk to people, so no one has to bring my iPad somewhere. It's already on my robot. But my staff keep telling me that they think that that would bother them if I sent a robot to check on them. We talk about workflow. We do a national training course on for at least our genetics providers, and I'm always surprised at the fact that a lot of providers don't know how the patient ends up in front of them. What paperwork has been done, what information has been gathered, how that patient got there, did they have to confirm their identity for insurance purposes? And so one of the things that we always talk about is let's try to map out what your in-person workflow is so that we can then create a telehealth workflow, because there are lots of things that don't work. You can't hand your patient um, uh, some information because you aren't there. You might have to email it to them, or some people, you might have to mail it to them for training. So we talk about training because one of the big things for my genetics providers when we started this a long time ago is they said they were never trained to use telehealth when they were in training to be healthcare professionals. And so they're unfamiliar with how to act on on telehealth, especially when it's audio, video, seeing each other. They don't like, especially in Hawaii, they're like, I can't hug them or touch them. And it's like, no, you don't need to. But, how do you act? Even things such as what to wear. Like if you love to wear really big, clunky, noisy jewelry, that is not going to work well in a telehealth session because that would be clinging and clanging as you're moving around talking to your patient. So even things like that that you don't think about in person. And then, of course, we talk about evaluation, because you're going to have to evaluate your services to be able to justify why you need better equipment, you want more money, you want your third-party insurance payers to pay for services. So we always talk about evaluation as part of it. So this is just an overview of a lot of things that we talk about. We're not going to go into any specifics about it during this session because it's a very big overview of what's going on. So as I said, we talk about staffing. How do you schedule? How do you work with the provider? How do you schedule their schedule with your schedule? Do you need someone to help present your patient? How are you going to document what happened? Is there a medical record you need to document in, or do you just wait for the doctor to send you an email with the note, or they mail you a note, or there's an EMR that's shared? How do you prepare your spaces for a visit? Is it going to be an exam room? Is it their common area? Is it in the resident's apartment or home? What kind of privacy are you going to have? Because what if you have more than one patient next to each other? What's the lighting like? It's just one of those things. We have our technical person who does all our training for us. She is she used to produce stage productions. And so she always says telehealth is all lights, camera, and action, because lighting is important. If you have someone looking at your patient and you have really bad lighting, they might not be able to see that the person's skin is jaundice. or that there's swelling going on somewhere, because maybe you have the person's skin kind of melds in with the color of the paint of the wall. And so if there's no contrast, the provider on the other end won't be able to see that that patient's jaw is swollen or something. So there's some things that we have to talk about when you talk about lighting and the environment. Also, internet connection. How much internet connection do you need? Can you do a cellular connection? How do you choose platforms based on that? And I know that as facilities, you might not have that much of a choice, because your providers will say, I want to use X platform, and you have to do it or else they won't give you the services. Scheduling, of course, will be a big thing, because I know that all staff are overworked, especially right now. And so scheduling and having staff being able to be available to help your residents is really important. And then now during COVID-19, of course, disinfection protocol is important. If you use a common area, what will be your protocol for disinfecting the area between patients? If you're carrying a device from room to room, what is your protocol for disinfecting the device between patients? So there are many devices and platforms. This is just a slide that shows you that we can use lots of different things. And that is one of the things that we can talk about during one of the TA sessions. Right now, because the Office of Civil Rights is not going to be auditing that you use a HIPAA compliant platform. During the public health emergency, you are allowed to use platforms such as FaceTime and Skype. Christina and I always want people to be able to do telehealth, but we also don't want people to get into bad habits. So if you can start with good habits to begin with and train your staff on good habits, then after the public health emergency, they won't be falling back on non-HIPAA compliant applications like FaceTime and Skype, because they will know how to use those HIPAA compliant applications. So we do want people to use good practice, but in this time of emergency, we do understand that FaceTime and Skype are platforms that are easy to access. People know them, and if you need to use them, then you need to use them. We talked about workflow, training, and evaluation. So this, as one thing I didn't mention for the evaluation, it is a good idea to not only evaluate what's happening in your own facility, but to also ask the provider how they, how did the session go? Were you able to give a good diagnosis or check the patient out? And also, it's a good idea sometimes to even evaluate the families of the patient to see if they felt that the care for their loved one who's in your facility met their satisfaction, that they didn't have to do a lot of extra steps to get their loved one to get health care services. And then the good part about the evaluation for us is it's always a continuous quality improvement loop for us. So it helps us adjust as we needed. The thing for us doing telehealth, so we do a lot of telehealth in neighbor islands. Our evaluator, after about 2 years, finally said, you need to give up on the patient satisfaction evaluation, because there is no one that is not satisfied with receiving telehealth on the family side, because they love not having to travel. And it's like, so there's just no need to keep collecting that data because it's always 5 out of 5. Even when the audio video doesn't work well, they're still happy because they didn't have to go anywhere. We had trouble actually on the provider side because they weren't as happy as the families. And I interviewed them and I said, what's going on? And they said, we just really like to touch the patients because it feels so impersonal through telehealth. And I told them they have to stop wanting to touch the patients. And the patients are really happy, and our outcomes were still as good for the patients getting the testing and the evaluation that they needed. So it was actually it was our providers that didn't like the telehealth as much as our patients did. So this is a list of technical assistance and support activities that Christina and I hopefully mostly Christina, supporting um, providers and facilities to do, talking, technical assistance about, how do you do reorganizing your team, staffing, workflow, facilities planning, device platform selection, workflow, protocol development, training. Jennifer is going to be helping us with that. Yay! Identifying telehealth providers, understanding payment, identifying funding opportunities. Now, one thing that Christine and I want to mention about the training is that we're usually on the provider training end, and so is Jennifer. So this will be a new thing for us. We do have we have worked with families to get good telehealth experiences, but we really have not worked with facilities to enhance the training on the provider side. So this will be a new thing for us. We know what should be done. I don't think we've just ever gone in and done it for people. So this will be interesting experiment for us. So we have the next polling question because we'd like to get an idea of where you need the most help out of those things that I talked about: staffing, facilities planning, device and platform selection, workflow, training, identifying telehealth providers, understanding payment, identifying funding opportunities. So if John can pull up the polling again, we can do the second question. You gonna go? Well, you know what? I'm going to move on, and then hopefully the question will be able to come out. So this is the last slide. So Christina wanted to tell you that on the PBTRC website, we have provider resources. These are aimed at the actual healthcare providers, best practices, quick start guides. My staff, we do a formal training, telehealth training, but we took all the best tips that we had and made it into a 4-minute best practices video for any provider that wants to provide telehealth. There's also billing and payment policy information on there. Now, we just stood up last week a patient resources site. This is the side that you might be interested in. It explains what telehealth is, there's a video on what to expect for telehealth, how to prepare for telehealth. There's checklists on what to do before a telehealth visit, during a telehealth visit, after a telehealth visit, how to get a telehealth visit, who provides telehealth services in Hawaii, and what telehealth costs, which is basically just a section saying it shouldn't cost more than a face-to-face, and maybe even less because you don't have as much transport or parking or other things that you need to do a telehealth visit. So
Okay, thank you, Sylvia. For myself, on the bottom of my Zoom screen, I see an icon that says polling. And if I click on that, the questions pop back up again.
Wow,
so that may be a way to find them. So we can take a look. Also, I found this out over the weekend that if you didn't update your Zoom for the latest version, then you may not have the polling option on your Zoom. Sorry about that. Just found that out. We do have some people who are putting in their comments. So I would like to recommend that if you don't see the polling happening at all, go ahead and put it in the comments section. So you're most interested in knowing the second question it's what topics do we need to focus on in the follow-up training sessions that will be much longer. Like, this is an abbreviated, half an hour. We'll probably plan for 1 hour training sessions, and we're going to start immediately, starting next week. So let's see. Should we turn, John, are you able to show us the results of the poll, the folks who were able to take it? Okay. Sylvia, you want to review?
So it seems like most people just started using because of COVID. Okay, that's good. That will be good because I think that will be covered in the first TA session next week. And most people need help We should put one for everything. An everything choice. Workflow, device, platform selection, some staffing. Okay.
Okay. No,
That's
that's
good.
great.
Yeah.
Yeah. So we anticipated that at least we'll start with the next week, Thursday, April 30th from 1 to 2. And that will be kind of a slower review of what you need to get started. And we will incorporate some of these, well, most of these things, but what we focus on, we'll take a look at this list here. I did want to say we do have Jennifer Boothia on the line. Jennifer, if you just want to pop in and say hello, she will be helping us with this training. She is a doctor that ran the Tripler telemedicine program. And so she has also a lot of experience with the operations and workflow protocol development. Everything will be different, right? Because we're, again, working with your facilities, which is a new area for all of us. And we will work with you together to figure out what the best workflows are. And I know that they will be specific to your organization as well. So the kind of support we can give you is more generic. This is what things to consider. And if there's some big need to figure out how we coordinate this at a higher level between the different healthcare organizations, that may be something that needs to be discussed as well. So with that, I'm going to turn it back over to you, Ada, to see if you want to take any. I don't see any questions, specific ones in the chat line. But if you had any echo announcements you needed before the close, we already went over 2 minutes. So back to you, Dr. Nguyen.
Yeah, no, I just wanted to see, get comments or thoughts from our participants, because these guys are really generous, and they're willing to help us get online to be able to do telehealth. I mean, I think that we're quite fortunate in Hawaii that we are not in the middle of a major surge right this minute, but I think we need to be ready before that happens. And so whatever has to happen to get you guys at least ready to go is really critical, and these guys are willing to do that. It won't be part of this ECHO series, but they are going to be taking it as an offshoot to start running different, I guess, helping sessions for you guys specifically. So yeah, and this includes different settings. So I know that long-term care facilities, nursing homes have different needs than assisted living facilities, and they have different needs in care homes. But everybody has a need to try to figure out the best way to get this working. So I'm just going to open it up to the floor for any comments, questions, or for your wish list of what would you like to see in for your facilities. What you think you need what do you think the barriers are, and what you would like help with? Just chime up or type in the chat box.
Thank you. We did get a comment saying interested in detail in definition of wraparound for telephonic services for full reimbursement for FQHCs. Yes, that is just out last week. So Sonia, we will get that information. I think a lot of it had to do with how you're going to document the wraparound services. It did not have to be provided right at the time of the visit, but the provider needed to be involved in the discussion and kind of the direction of those wraparound services. So for the FQHCs, she's asking specific wraparound services. So I'll need to follow back up on the details of that. The Medicaid memo that came out did not specify, but we are meeting with the FQHCs through Hawaii Primary Care Association every Friday as well. And we are having virtual telehealth roundtables, so that would be a good discussion. I'll let them know that we'd like to have more discussion on the specific services that would count as that. It was quite vague in interested in hearing about billing for hospice and telehealth assessment visits. Okay, I will have to get that information and we can make sure that's included in our follow-up training. Not to confuse everyone about all the different training that we're doing, but Sylvia and Sylvia, she's so generous. She's not a part of PBTRC or my team, but somehow she and I just partnered up. She's at the Department of Health and has her own projects, but because the TA, the technical assistance requests were so overwhelming, we actually decided to partner up and hold every Friday from 10 to 11. It's a general telehealth 101 office hours. At that time, we do the updates on policy and go over all the frequency asked questions that came in through the week. And then the afternoon on Friday, we work with the FQHCs because they're very specific. Their billing is different. And then now we're hoping, hopefully it's a set day on Thursdays with your group because it's all slightly different perspectives of telehealth. So the focus will be different. Okay. Yeah, I think we may have addressed all the questions that have been coming in on chat.
Okay.
Oh,
Christina?
yes.
This is Jennifer. I actually have a question for the group or for Ida. If we could get an idea of what the current coding and billing that is done by the facilities themselves, as opposed to the physician who comes into the facility, might prove helpful as we are learning how to best support long-term care facilities and hospice care, because I know that there's some codes, HCFIX codes, facility codes that are associated with the actual facility where the patient is housed doing telemedicine. But first, it's helpful to know what the current face-to-face codes are, if any, that the facilities are using when a provider comes into the facility, or if they have to make any sort of arrangements. That would be just helpful information to gather offline.
Okay, yes, thank you, Dr. Booth. Yes, so that is information that, as Jennifer mentioned, that we are not that familiar with what your facilities do, what they bill for. So if you can let us know if it's a facility fee or that's connected and tied to these telehealth visits, that would be helpful. Or if you don't know and you need us to kind of do a little bit more research in that area as well, that would be good information.
So Ada's group they'll send out information about the TA next week on Thursday from 1 to 2 on what the Zoom link will be.
Yes.
Okay, so yeah, we'll have another meeting this coming Wednesday. We have another topic, isolation and quarantine of staff. But right before that, start of that, we're gonna give you more details about the link and the information for the telehealth thing for Thursday. That's gonna be run by these guys. So thank you very much.
Thank you, Dr. Wen, for coordinating all of this. And yeah, we will continue to share information of the external spin-off training that came from here, so you can inform the group for those that maybe didn't join us next week. If once we start to get into a regular routine, you can announce it during your echo sessions as reminders to everyone.
And if you have more questions, feel free to email Christina so that we know what you want.
Yeah. Christina, what's your email? Can you type it into the chat box?
Yes, I will type it into the chat box. So I'm with the UHPBTRC, and I'm looking for where's everyone. Okay, so my email is Christina@uhchasi.org. My website is pbtrc.org, right?
Mm-hmm. Okay.
Okay, and if you go to that website, you will also see a contact form that you can fill out, and someone will get back to you. It will have, we will capture all of your information. So we have your contact information, and then your question can be added there. So that's probably the best way to submit a question to us. But if anything else, you can also just call me. This is my number. I didn't, 808-956-7224.
Okay, great. And our goal is, of course, to get 100% of our facilities and care homes and assisted living to be able to do this telehealth. Because once a case gets into your place, you'll pretty much be on lockdown, and no providers are going to be coming in. So we really need to be ready for that. Okay, so anyway, just in conclusion, just a reminder, if you want to get a certificate of attendance, go to our webpage, complete the online evaluation form. There's a link at the bottom of the email invitation. And any comments or questions for the planning committee, that would be great. And that way we'll be able to answer your questions and meet your needs. So hope to see you Wednesday, talking about isolation and quarantining of staff. And we're going to have our good friends from DOH back online at that point. See you then. Thank you.
Thank you.